All right. We're going to go ahead and get us started. Thank you all so much for coming. Really do appreciate you all being here on a Sunday evening. Obviously, food helps, but I really do appreciate it. This is a very exciting time for us in neurology, very exciting time in Alzheimer's disease. My name is Jordan Mast. I am a PA at the Colorado Neurological Clinic. I've been in practice with general neurology for about 13 years. I'm very excited to be here alongside two of my colleagues, Dr. Kristen Cutts. She didn't want me to say that. She's a PA PhD. She's been in practice in neurology for, 25 years. Brilliant beyond brilliant, amazing person. And then Dr. Adam Wolf. He is the physician that basically got me started in neurology. I was a student with him 13 years ago from Midwestern University, brought me on board, and then hired me right out of school. So I'm really excited to be with both of them today. So again, introduce myself. This is sponsored by PeerView. This is a CME talk, so you are getting CME for this, but it is from an educational grant from Lilly. Really important that I want a lot of feedback. I want a lot of interaction. There are going to be some breakouts, but even before we do the breakouts, I want you to be submitting questions. There are going to be some polling questions as well. In fact, if you do participate, and the more you participate, there will be a drawing for some gift cards. So, and the more questions you ask and the more polling you do, the more likely you'll win. So I would highly recommend you do that. We do have the ability to see these questions. I also really appreciate those that are online. I think we have quite a few registrants online, and they also have the option to submit questions as well. So be on the lookout for that. There are QR cards at your table. Also, thank you for the facilitators that took time out of your busy days. I know some of them personally, one of which has a newborn at home. So thank you so much for that, for being here. Again, there are QR codes at your table, but there's this one too. There is not just one $50 gift card. Apparently there are multiple. I'm sorry if that's not correct, but that's what they told me. And then at the end, please look to see if you have something green on there that says you're a winner, and then you can go to the PeerView people and get that gift card. Again, PeerView, you can get these slides online if you go to this website, and again, if you can go to the QR code. This is a pretty dense slide. I'm going to be honest with you. We actually trimmed it up a little bit, but for those of you that are interested in kind of spending more time looking through these, I would highly recommend you download these slides. You can go to this. You can email PeerView, or you can obviously go to that website and pick it up. And then there are also some practice aids on there. I went to the slides on my phone just a little bit ago, and it's pretty neat. PACE ALZ is another resource that I would highly recommend you look at. These are CME-specific videos and things that you can do that are specifically to Alzheimer's disease. I would highly recommend you look at that, especially if it's something you're interested in. PeerView also did a brain health workshop on Friday night. I know probably some of you might have been there, but this is, again, it's a very exciting time for those of us in neurology. So these are our goals for today. We're going to start off by discussing some of the advances that are being made in Alzheimer's disease, specifically in the realm of biomarker testing. There are some new therapeutics that we're going to be discussing as well. We also want to discuss how there's the correlation between some of the pathophysiologic changes that are occurring in Alzheimer's disease and how that correlates with clinical symptomatology, and what does that mean, and how important it is to recognize these diseases earlier. And then we're also going to discuss some of the new biomarkers, and then how do we basically manage patients throughout the disease progression. So again, I already introduced myself. Again, I'm Jordan Mast, PA at Colorado Neuro. I think it's pretty safe to say that most of us in this room have some sort of connection or familiarity with Alzheimer's disease, whether it be in your clinical practices, whether it be personally. I have a connection in both. It is exceptionally prevalent. It is extremely disabling. When we talk about dementia, which is a clinical diagnosis, specifically looking at functional decline in patients that have basically a loss of independence. When you're talking about dementia, the majority of dementia is Alzheimer's. This says 60 to 80%. I've always said 50 to 80%. But in the past, when we had patients with dementia, we really just had to guess, and statistically speaking, we were usually right. But now we have more and more access to diagnostic testing that gives that diagnosis more accurately. And unfortunately, the number of patients with Alzheimer's disease is projected to double within the next 35 years. There's a lot of reasons for that. Aging population is a big part of that. And we are already very we're struggling with the number of patients, and I certainly am very much an advocate for PAs going into neurology, but really giving you guys the tools, for those of you that are in the geriatrics practices, primary care practices, giving you guys the tools at your disposal in order to be able to help manage these patients is really key. So why is it important to diagnose Alzheimer's disease early? I mean, that's a pretty obvious question, I think. We want to catch these patients earlier because there might be something we can do about it. We also want to validate patients' concerns and their family members. We have more tools at our disposal. And certainly, diagnosing these patients earlier give them more access to therapeutic options. They give them more options for possibly social work. And so that's really the emphasis right now, is trying to instill and empower PAs in primary care and geriatric offices to recognize this disease earlier and earlier. And the majority of these patients are in your practices. And the majority of patients that get a diagnosis of Alzheimer's disease, or dementia, I should say, are in primary care offices. But it really does help to catch these patients as early as possible. So I'm going to pass the buck to Dr. Adam Wolf.
Thank you. Thank you, Jordan. Hi, everybody. Thanks for coming. I really appreciate the opportunity of being here. I can't decide if I want my glasses on or off, so for those of you who are young, you'll understand one day, but I'm trying my best. But anyway, we're going to talk about mapping the Alzheimer's disease continuum, biomarker-driven insights for early diagnosis. So let's back up a second and just get on the same page with some of this terminology that I think you probably understand, but just to go over it, Jordan mentioned it earlier, but dementia is a clinical diagnosis. It means that you're having trouble with your memory or cognitive functioning, and you need help with your activities of daily living. Alzheimer's disease is the most common cause of dementia in our country anyway. And Alzheimer's disease is a pathological diagnosis, meaning that if we were to look at your brain under a microscope, we would see accumulation of two toxic proteins, amyloid and tau. There are a number of causes of dementia, Alzheimer's again being the most common, but there's vascular dementia, frontotemporal dementia, Lewy body dementia, to name a few. Those other diagnoses get to be smaller and smaller in terms of percentages. Alzheimer's disease is the elephant in the dementia room. If you have memory issues but are still independent with your activities of daily living, we call that MCI, or mild cognitive impairment. This slide's important. It talks about that Alzheimer's disease continuum. Preclinical Alzheimer's disease, stage 1 and stage 2, that's when you're having the buildup of the amyloid and tau proteins in your brain, but you're still doing well functionally and still doing well from a memory standpoint. In the future, this is me guessing, but in the future, we're going to be looking for people in this preclinical stage to try and knock out these amyloid and tau proteins before we get to the necrosis stage, or the stage where we're losing neurons. Right now, we have treatments available for people in the MCI stage and in the mild dementia stage, and we're going to be talking about those tonight with you. But you'll see some evidence later that we are studying the preclinical stages, and take-home message for all of you is the earlier the better. Once we get to moderate or severe stages of dementia, our treatments are less effective. So the pathophysiology of Alzheimer's disease, can't explain this in one slide. Nobody fully understands it. This slide was a lot more complicated, but to simplify it as best we can, we sort of use this hypothesis called the ATN hypothesis. Amyloid pathology builds up first. I may have seen some of the test questions. I'm not going to tell you for sure, but amyloid pathology builds up first. All right. Then there's tau. Tau starts to come in second, and then there's necrosis or neuronal injury or loss of brain cells. So basically, amyloid, tau, neuronal injury, or loss of brain cells. You can see that sort of, let's see, I got this power here. You can see that depicted by this cool green pointer I have, but the amyloid precursor protein gets cut or cleaved abnormally. It starts to polymerize or form these larger clumps of proteins that eventually lead to amyloid plaques. Amyloid plaques are toxic on neurons, and then tau also starts to tangle up into these neurofibrillary tangles intracellularly, and both of these amyloid and tau proteins are toxic on neurons. Also, important to note, just FYI, that neurofibrillary tau tangles develop later and correlate with clinical symptoms. You can see phosphorylated tau in the CSF or blood before you see tangles, just FYI. I'm trying to help as best I can. All right, so this is a really cool slide. It sort of illustrates a lot of what I've been talking about here. Biomarker changes in Alzheimer's disease. You can see that about 20 years before patients present to us or to you guys in the clinic, their amyloid is building up. Then their tau starts to build up. Then they start to get basically neuronal or brain cell loss, mild cognitive impairment, and then they go into the dementia range. So again, earlier the better, before you get to the catastrophe of the tau building up. I did not coin that term, just in case you're wondering. But before we get to this tau problem, if we can intervene and hit this amyloid, we're probably going to do a better job of saving neurons. And then we have this fun blue slide here. Answer this question on your device, please. And I'm just going to take a couple of seconds there. All right, and now I think I get to pass along, well, one more, making a biomarker-based diagnosis. So I'm going to introduce the biomarkers. So basically, it used to be that we couldn't diagnose Alzheimer's disease until after you had passed, and we could look at your brain under a microscope, which wasn't very helpful for you. But now, since the advancement in our ability to test for these amyloid and tau biomarkers, we can diagnose Alzheimer's disease while you're still alive. And in fact, we can even see pathological changes concerning for Alzheimer's disease before you have any clinical symptoms of Alzheimer's disease. These core-1 biomarkers can be seen in the CSF and on imaging with PET scans. CSF and PET can measure amyloid, and CSF and PET can measure tau as well. Tau PET isn't commercially available, but it does exist. And then in the blood, we can test biomarkers as well. The p-tau217 is one that I want you to burn into your memories as best you can. p-tau217 is the best blood-based biomarker available right now. They're available at a lot of commercial labs. They are generally not cost prohibitive. So I do think all of us will be ordering a lot more blood-based biomarkers in the future as those improve. And to talk a little bit more about biomarkers, one of my very good friends, Kristen Coots.
Thank you for having me, and I am also going to rock my reading glasses on top of my head.
I know, it's so tricky. It's like, just far enough, not far enough.
So I'm going to be talking about improving Alzheimer's disease detection with biomarker testing. But first, we want to go over, that this is a team-based approach, detecting, assessing, and ultimately diagnosing Alzheimer's disease. So as far as the initial detection, you can see there's a long list of providers that can be involved. APPs are number one on the list, as you can see. Anyone here in neurology? Couple. And how about primary care? A lot of you, yeah. And how about psychiatry? Okay. So all of you, or at least we can share from our own experience, we typically will have a patient or a family member come into the office and express concerns about having some kind of cognitive decline or cognitive concern. So the first thing that we do is get a patient history. learn more about their medical history. We want to know more about their family history, particularly do they have a family history of dementia. And then we can do quick cognitive screenings in the office, like MOCAs are pretty common, MMSE. And then depending upon what we find, we might move along in the diagnostic process to assess for potential causes of cognitive decline. So first thing that I usually do is get some blood work to rule out reversible causes of memory loss. Like for example, if there's a B12 deficiency, you want to identify that, treat that, and patients' cognitive functioning could potentially improve. Want to do the neurological physical exams, do more cognitive and functional assessments, which we'll talk about in the next slide, and then get imaging of the brain to evaluate for any structural abnormalities. And then finally, getting more towards the diagnostic phase, we now have biomarker testing, which we'll go into more depth as well. There's CSF, there's serum, there's PET imaging ways that we can look for these biomarkers. And then once we identify our workup and we feel as though a patient likely or probably has Alzheimer's disease, we want to talk about what to do next. What are their treatment options? So as far as the diagnostic workup, you could see everything on this list. This can be done in a primary care setting. This could be done in a neurology setting. Any specialist who potentially is seeing patients with cognitive decline. So again, you want to check the patient's medical history, surgical history, really dig into their family history to see if they have any family members with dementia. The caregiver perspective or family member perspective is really important too. Oftentimes they're giving us a lot of insight, and sometimes they don't necessarily want to share that in front of the patient directly. Go over their medications. Make sure that they're not taking any medications that could be contributing to cognitive decline, or look for polypharmacy. Dig into their social history, ask about smoking. Excessive alcohol use can oftentimes cause cognitive decline as well. Laboratory testing, as I mentioned, looking for all of those reversible causes of memory loss that can be evaluated. The neurological examination is helpful to rule out non-AD sources. So on a neuro exam, you can pick up Parkinson's disease, or if they have signs or symptoms of a stroke, you can identify it that way. As far as the brief cognitive assessments, I would say for us in our practice, we're using probably MOCA, most often MMSE to a certain extent. If I see any abnormalities, or any areas of deficiency on, say, a MOCA, I'll usually order full neuropsychological testing on the patient. Functional assessment is really important too. So having an understanding of what their activity of daily livings are like, what kind of impairments that they may have. Behavioral assessments are also important too, especially if they're potentially being aggressive to family members. Brain imaging is important to rule out any structural abnormalities. So MRI brain, you can do neuroquant with it, is preferred, but if you have a patient with a pacemaker, CAT scan will do the job too. You're ruling out like NPH or stroke. And then biomarker testing is really going to be, I think, the mainstay of treatment. And so how do you know if biomarker testing is right for your patient? So there's a couple things, and this, just a quick hint, is going to be a test question. So who is it indicated for? So it's indicated for patients who have objective evidence of cognitive impairment, who are undergoing a diagnostic workup. It's not recommended for patients who are asymptomatic or don't have any cognitive impairment. So you're trying to use the biomarker testing to see if Alzheimer's disease specifically is a cause of the impairment. And then also too, if having that diagnosis could potentially offer them treatments, such as the amyloid targeted therapies, which we'll be going over later on in the presentation. And here's your first polling question in my section. Mm-hmm. Okay, now we're going to get into the nitty-gritty of the different biomarker tests that are available. So amyloid PET has been the gold standard up to this point. As far as what happens with a PET scan, a patient is injected with a radiotracer that binds amyloid plaques. And then the PET scan images show the radiotracer binding. And if you look on the right, you can see what a negative and positive scan can look like. It's interpreted typically as positive or negative. Some software will allow for it to be quantified in centiloids, but in my experience, I've really only seen that in a research type setting. As far as the advantages, you can see the amyloid plaques, you can see where they're distributed, it's FDA approved, it's covered by Medicare. What else is kind of interesting is if you are using these amyloid targeted therapies, you can do a follow-up PET scan and see how much amyloid has essentially been removed through the therapy. Drawbacks are it's expensive, it does require specialized equipment. Not all imaging facilities have PET scans, and I think as a result, at least in Colorado Springs where I'm at, we see a backup where there can be a several-month wait for a PET scan, and it does require radioactivity. CSF biomarkers, the patient will undergo an LP to collect CSF. You can basically get concentrations of certain proteins in the CSF, and if you look to the right, a positive value is essentially decreased beta amyloid in the CSF and elevated tau proteins. Also FDA approved. It's also kind of nice because in the CSF, you can also be testing for other causes of cognitive decline, like you could rule out neurosyphilis, encephalitis. You can also do ApoE genetic testing at the same time. As far as the downsides, I haven't really encountered too many patients over my years that love lumbar punctures, so that's one of the drawbacks. Some patients just can't have lumbar punctures, and then can be time consuming. You have to send out the CSF, etc. Blood-based biomarkers. This is really, I think, going to be more of the mainstay of identifying these proteins. Patients essentially just have to undergo a blood test, and then certain proteins in the plasma serum are measured, particularly beta amyloid and p-tau 217. It's interpreted either as positive or negative or intermediate based upon the cutoff of the specific lab. The advantages are it's obviously more accessible. It's just a simple blood test. Patients don't need to fast for it. It's less expensive. On Friday, the first blood-based biomarker received FDA clearance, and there's a whole slide dedicated to this coming up. So as far as the disadvantages, it may not be reimbursed by Medicare. I can't say that that's been the case for any of the patients that I've ordered it for, but certainly reimbursement could be an issue. Some tests may not perform consistently depending upon a patient's comorbidities, like for example, if they have chronic kidney disease. And then you can't necessarily quantify amyloid clearance with these blood-based biomarkers yet. So just this past Friday, the FDA granted clearance for Lumipulse G p-tau 217 beta amyloid plasma ratio for the detection of amyloid plaques associated with Alzheimer's disease in patients 55 years or older. They have to be symptomatic, indicating that there's some cognitive decline. It's the first FDA-cleared blood test to test for Alzheimer's disease. It's not considered to be a standalone screening test, so there has to be other supporting evidence of Alzheimer's disease present. And then how it essentially got FDA clearance was based upon a clinical study of 499 patients. The positive predictive value for the test was 92%, and then negative predictive value was 97%. And then, are these blood-based biomarkers ready for widespread use? Here are some statements, consensus statements that have been made. This may be a test question too. So you want to consider the minimal acceptable performance standards for AD blood tests in clinical care. So as far as the consensus, they're recommending 90% or greater sensitivity and specificity for amyloid PET status to confirm testing. You want to identify which of these blood-based biomarkers are meeting the standards of the Alzheimer's Association's recommendations. And consistently, p-tau 217, as Dr. Wolf mentioned, is outperforming the other blood tests. And then now that there's regulatory approval of p-tau 217, I think we're hoping that the coverage with different insurances is going to improve dramatically. But it's important that we're educating clinicians, how to order the test, how to interpret the test, and what to do with those test results. So this just provides a potential pathway. Did you want to? Got it. Thank you so much. So there's two different ways we can order, these tests. So certainly in a primary care setting, as most of you, are coming from, you can certainly, order these tests yourself. If you have a patient who's coming in and they're expressing concerns about cognitive decline, or you have family members that are expressing concerns, you can pursue some of the workup that we had talked about. Get those laboratory tests, look for reversible causes of memory loss, do some cognitive screening testing in the office, get that MRI of the brain to rule out other structural abnormalities. And then if you feel comfortable, order the blood-based biomarker testing. Depending upon the results, you can discuss them with the patient yourselves. You can refer to neurology or to dementia specialists. We can certainly help patients interpret these results and talk to them about some of the amyloid-targeted therapies. If we get to that stage, we're going to most likely do ApoE genetic testing, which also helps guide our treatment decisions for patients. And then this is kind of a nice slide because it tells you on the left all the different labs that offer p-tau 217 assays. And you can look at the test name on the right, but this is just a great resource depending upon what lab availability you have in your area. And here's another polling question.
I love seeing everyone pick out their phones. That's great.
And we're getting lots of Q&A.
I know, we're having some good questions.
It's doing good. Okay, and I'm almost wrapping up my section. But when you're having these discussions with patients and their family about these new biomarkers and treatment options, you really want to try and get an idea of what the patient and the patient's family's goals are. You want to understand what their preferences are. Some patients don't want to know. They may not want to pursue genetic testing. They may not want to have biomarker testing because they're concerned at how that might, impact them socially, professionally, et cetera. So you really want to kind of gauge what their treatment goals are and then offer support to both the patient and family no matter what they choose to do. And then it's really important to set realistic expectations. So these biomarker tests, well, they do give you potentially a high likelihood that this could be Alzheimer's disease. They're not necessarily 100% definitive. And then also too, talking about these amyloid-targeted therapies, they're not cures, but they do significantly reduce amyloid lesion load and slow down the progression of the disease. And then lastly, for me, this just gives a step-by-step summary. So say step one, you have a patient, comes in to see you, it expresses concerns about cognitive decline. You can start that diagnostic workup, kind of confirm whether this is MCI, is this mild dementia due to Alzheimer's disease, do that medical history, assess their risk factors, rule out other neurological conditions, get baseline cognitive testing done. You could do a cognitive screen in the office. You could do full neuropsychology testing. Then you want to get the blood work done to rule out all of those mimickers or reversible causes of memory loss, and also rule out any non-AD etiologies. get the MRI done to evaluate for any other structural abnormalities. Once you hit step 3, you likely have a suspicion that this could be Alzheimer's disease, and that's when you are going to want to discuss biomarker testing with the patient and their families. And if you have a patient who's interested in biomarker testing, you can order the test that's most feasible. I do think the blood-based testing is going to become more common, where historically it's been primarily, I would say, PET scans. Order that biomarker testing, and then based upon the results of those testing, you can refer to neurology to discuss the results as well as potential treatment options. I think that is one more.
One more.
I know, lots of questions in my
you get all the
section.
questions. All right. Well, thank you so much, Kristen. I appreciate it. I was bad, and I did not read the test beforehand, so I have absolutely no idea what part of my section actually has questions. So I apologize in advance, but I'm going to try to be comprehensive in going over my section. This is going to be a conversation about how do we manage Alzheimer's disease throughout the continuum of the disease itself, starting at the earlier stages and progressing. So what are the goals of Alzheimer's disease treatment? I mean, you know, when you're talking about anything medically and you're talking about goals of treatment, a large portion of that really depends on what you're treating. Certain diseases, you want to cure it. Well, you want to cure everything, obviously. But realistically, some conditions you want to cure. Some conditions you want to just symptomatically improve. Some you want to delay progression of disease. And in Alzheimer's disease, really the focus right now is delaying progression. You know, we've talked about removing amyloid plaque, which is certainly beneficial, but how does that carry over into the actual disease process? And what it does, and Kristen said this very eloquently, that it delays the progression of the disease, and you can see that with the data. With that also comes quality of life, preserving that quality of life. Certainly during the disease, you can also use symptomatic therapies, which we'll get into. But probably one of the most important things for us, and a very strong focus, is supporting the loved ones, because this is an exceptionally difficult disease to treat. It's an exceptionally difficult disease to manage, and we see them for 30 minutes at a time, an hour at a time, but their loved ones are with them essentially 24/7. So it's an incredibly important aspect of treatment. So, obviously there's multiple ways that we can treat patients with Alzheimer's disease. We talk about things like lifestyle and dietary things and staying active. I remember seeing Dr. Wolf's notes when I first started, and this was before the amyloid targeted therapies came out. And I just remember every single one of his Alzheimer's disease patients, he would put in the plan, stay active, all caps, exclamation point. It was like every time I'd see that, I'm like, okay, that's a very important thing to mention. But from a pharmacological perspective, what are the difficulties? Well, certainly these patients are older. They have multiple comorbidities in many cases. They're potentially on multiple medications. Their pharmacokinetic kind of issues, physiologic changes that occur in older patients also prove to be challenging. So these are things that we have to keep in mind ultimately when we're talking to these patients. We don't want to over-medicate them either. So it's a very challenging population to treat, especially for those of you that are in geriatric practices or have a high geriatric population. Many of them are on 10 or more medications, and if not a larger number. So when we see these patients with early stages of Alzheimer's disease, what types of focus do we have? Well, obviously we've talked about amyloid targeting therapies. That's really where in the MCI and mild AD stages where the focus is, but that does not mean that we don't recommend lifestyle modifications. You can also use some of the cholinesterase inhibitors, what we call the symptomatic medications for Alzheimer's disease, like donepezil. Many of us have used donepezil, memantine. These are fine medications to still use. I think in the clinical trials for the amyloid targeting therapies, in upwards of 50% of patients in the studies were on these therapies. So use them. I mean, these not something we need to be scared of. Certainly there are implications from a side effect perspective. And then in the moderate stages, this is when we start really losing a little bit of option in regards to delaying progression, but you can still use cholinesterase inhibitors, memantine, behavioral symptom management. Later stages of Alzheimer's, certainly there could be some behavioral problems. You can see it earlier in specific types of diseases. In fact, sometimes neuropsychiatric symptoms are the first symptoms that arise in Alzheimer's. So that's actually a very important point to make. but it is something that we focus on. And then education of the care partner. And then the late stages, this is when it gets really, really challenging. And I'll just send them back to you guys in primary care so you can manage it. No, I'm just kidding. This is where we really want to help support the family, talk about long-term palliative care options and things like that. But we're really trying to prevent patients from getting to the second and third stage. To Dr. Wolf's point about, asymptomatic Alzheimer's, we're not there yet, but we certainly want to try to prevent people from getting to these stages. These are some of the symptomatic therapies. They're still used to this day. We still use them all the time. They don't really delay progression. They just might help the patients. They've been around for years, decades even. You can see the adverse events there. Generally well tolerated. I always like to say sleepy, dopey, dizzy, but there's, the listed there. Our most common is donepezil and memantine, and then there were some combo drugs that came out from pharma just to make some extra money. You can use these that are generic therapies and don't contraindicate patients from some of the newer therapies. From a kind of neuropsychiatric perspective, this is where it gets a little tricky, especially with comorbidities. We still certainly will consider using antipsychotics, antidepressants. If they're having sleep issues, consider sleep medicine. But these are tricky drugs, right? They're challenging. And if you look at antipsychotics, they all really have a warning against use in dementia-related psychosis. So we say it, we use these drugs. Even brexpiprazole, which is indicated for dementia psychosis, has a box warning for dementia psychosis. So it's very, very frustrating. There is a lot of research being done in the management of Alzheimer's disease symptoms, but this is, again, not to sound like a broken record, this is why we're trying to catch these patients earlier and earlier and earlier and earlier so that we don't have to worry about putting them on quetiapine or something like that. So major, major challenge, but these are still utilized. So let's get into the meat and potatoes. So disease-modifying therapies, or DMTs, which was popularized in MS, but now we're starting to use it in Alzheimer's, which is really, really exciting. So, the first drug that I ever heard of was aducanumab, and aducanumab had I think it was a fast-track approval that unfortunately got pulled from the market for a variety of reasons. The other two listed on the bottom are not FDA approved. Lecanemab and donanemab are the ones that are currently FDA approved. Lecanemab was FDA approved in July of 2023. Donanemab was July of 2024. And these therapies, all of these therapies target amyloid. And they each target it in different ways. You can see on the right that they show that donanemab specifically binds to the plaques. Lecanemab binds to other areas, does bind somewhat to amyloid plaque too. The long and the short of it is we don't know why one might be better than the other, so certainly we can't draw any comparisons that way. But the intention really is to remove amyloid plaque from the brain. So again, these are really the most exciting breakthrough that we've had in neurology in a really long time. And the idea here is, of course, we want to see people get better. We haven't gotten that yet, but we also want to see people have a delay in progression. But ultimately, we know that amyloid and tau are toxic. And I've heard Dr. Wolf say it a million times. The goal is to get rid of amyloid. I mean, you have amyloid, and we don't want amyloid. That's it. And these drugs are very effective at that. They, in many cases, can remove amyloid completely within 12 months of treatment. These two drugs specifically were studied over 18 months, but there were some of the studies even showed amyloid completely being removed as early as 6 months after treatment. But the goal of treatment is to remove that amyloid. Between these two drugs, we're talking a decline or a delay in decline of about 20 to 40%. Generally about 30% is what I like to tell my patients. The middle column, that bottom statement saying you get a saving 5 to 7 months, that's really difficult to know for sure. I mean, these are short studies in the lifespan of an Alzheimer's patient. There are currently being done extension studies. So really excited to see long-term data. And then, of course, to Dr. Wolf's point, looking at potentially pre-symptomatic, which is also being studied right now, but beyond the scope of our lecture today. But probably the most important conversation to have aside from that efficacy side of things is what is the risk? And if there was no risk for these medications, I'd be like Oprah. It's like, you get anti-amyloid, you get anti-amyloid. But the problem really is they are not risk-free. They are monoclonal antibodies that are infused. They do have the potential for infusion-related reactions. Many of us have probably utilized or are aware of the infusion drugs that are out there. This is no different. But really the big one is something called ARIA, which stands for amyloid-related imaging abnormalities. We're going to discuss it in a little bit. And ARIA is something that was a concept that was kind of known, and we'll get into that a little bit, but has become much more widely understood or widely discussed because of these amyloid therapies. And then there are safety monitoring things, which is more what we're responsible for. So let's talk efficacy to start. So lecanemab's primary study was called Clarity AD, and this slide specifically shows reduction of amyloid over the course of the 18-month study. And the take-home message here is it does the job. It removes amyloid, right? You can see that on the left. On the right hand, this is from an amyloid PET scan. You could see separation from placebo as early as 3 months, but people certainly at the 18-month mark were essentially negative on their amyloid PET scan. And in the CSF side, on the right side, their CSF also normalized. From an efficacy perspective, ASI looked at both the cognitive function. They looked at ADLs. They looked at a lot of other things, and it basically met all its endpoints. You can see on the left-hand side, the top left-hand side was the primary endpoint, looking at something called the Clinical Dementia Rating Scale, sum of boxes, and there was about a 27% reduction or slowing of decline. It's always weird when I talk to patients about how you have to word that, because you certainly don't want your patients to think they're going to get 30% better. I've had that happen a few times. That is not what we're talking about. The ADCS-MCI-ADL is a rating scale that looks at specifically at ADLs. It's given by the caregiver about how their loved one is doing. And then the other two on the right-hand side are a few other secondary endpoints, and they all met their end goal. So there are some limitations in the study. We actually see the limitations in the donanemab side of things too. It was an 18-month study. It was actually done during COVID, which had some challenges, whether it be missed appointments or delays in treatment, things like that. There was also, I actually had this a little bit happen because we were in some of the studies as well, where if you experienced a side effect to, let's say, the infusion, it kind of unblinded them. So if you had an infusion-related reaction, it's like probably not placebo, right? And there's really no way around that. If they start getting tachycardic and develop hives, most people that have any wits with them, they'd be like, it's probably not saline. So that did, unfortunately, unblind people. There's no way around that. And donanemab suffered from the same thing. Donanemab's primary study was called Trailblazer. Again, you saw a reduction in amyloid plaque on the amyloid PET scan over the course of time. The donanemab study was a little bit unique in that they were looking at patients that had a lower level of centiloids, which is beyond the scope of our conversation today. Centiloids, I think Kristen mentioned it really well. But they were basically looking at, does their amyloid PET scan become negative? I mean, for all intents and purposes. And they were actually able to switch over to placebo. It was blinded, so they were switched over to placebo, not stopped. And now that the drug is FDA approved, patients can actually stop drug once their amyloid PET scan is negative, which is a really cool thing. It also had, with donanemab study, it actually subdivided patients in the low to medium tau group. When you look at the Jack curve that Dr. Wolf went over, when you think about amyloid being the first to develop and then tau came later, if you subdivide patients that were in the low to medium tau groups, theoretically those patients are earlier on in the disease. So they wanted to subdivide those patients to see, did they do differently than the entire cohort together? So the left-hand side looked at efficacy using something called IDRIS, which was developed by Eli Lilly, which was a functional and cognitive assessment tool. And you can see that the percentages actually looked better in the low-medium tau population. These all really met endpoints, so it's not like it didn't work in total, but the statistics look better for those low-medium tau population patients. I think really the take-home message here is, which we've been saying over and over and over again, catch these patients earlier, because they're probably going to do better, right? In the past, it was really, really frustrating because we couldn't do anything for these patients. We didn't have diagnostic testing for these patients. So if someone came to us for mild cognitive symptoms that seemed pretty minimal, we just say watch and wait. That's a big thing in neurology, watch and wait, watch and wait. This is actually getting to a point now where we absolutely do not want to do that. The earlier, the better. Trailblazer had some limitations as well, very similar limitations. It was an 18-month study. There is an extension study going on. There were some demographic issues. 91.5% were Caucasian, so there was some lack of racial diversity. And then the same thing I mentioned before about if they had any ARIA or infusion-related reactions did kind of basically unblind people, so something to keep in mind. So what does ARIA actually look like? When I was in my ER rotation, I absolutely adored just looking at CAT scans and MRIs and x-rays just because I love pictures. I never grew up in that way. So you could see ARIA here in the bottom. ARIA is subdivided into ARIA-E and ARIA-H. We just basically think ARIA-E stands for edema and ARIA-H is hemorrhage. You can see on the E side that there's something as simple as just a little bit of edema. You can have sulcal effusions. On the right-hand side, you have ARIA-H, which basically presents as microhemorrhages on the brain. It's important to mention, and this is actually, I just called a radiologist. I called Jared Mahan earlier today because I was curious. This whole idea of cerebral amyloid angiopathy, if any of you guys have ever seen possible CAA on an MRI or a CAT scan, those are microhemorrhages, and they're evidence of ARIA for all intents and purposes. And so that is a contraindication, or it at least needs to take pause. If you have someone with multiple microhemorrhages, it's probably not a good idea to go on these therapies. The other important thing to note is when ARIA does occur, vast majority of the time it's asymptomatic. So these are not largely significant symptoms that you're experiencing. In fact, it's so commonly asymptomatic that the first 6 months of treatment on these therapies, we're doing multiple MRIs to see if they're having asymptomatic ARIA. And most of the time, it just goes away on its own. Certainly, there is the potential that more things can happen. There were, unfortunately, a few fatalities, which we can discuss at any point. These were some of the statistics here. Very, very important to note that these are two completely separate studies. So the two on the left, lecanemab and placebo, and donanemab and placebo, are two completely separate studies, completely separate cohorts of patients. But you look at ARIA-E on both ends, and then you looked at symptomatic ARIA-E. This is something that should show you that the majority of these patients are asymptomatic. Infusion-related reactions very common, and very few patients actually discontinued because of adverse events. So donanemab actually recently came out with some information regarding doing alternative dosing. This is not yet FDA approved. It's a little bit beyond the scope of our practice or of our conversation today, but the take-home message here is there's currently underway a alternative dosing for donanemab. Instead of doing the half dose for three months and then the full dose after, you actually kind of build up more slowly over time, and it did cut down on ARIA rates. And it's in front of the FDA now. We're still waiting. Infusion-related reactions extremely common. This is something that you'll be very manageable in most cases, and typically only happens in the first 2 infusions. So go ahead and take it from here, buddy.
Thank you, Jordan. All right, let's talk about patient selection for treatment with AATs. One little point about Jordan's section where he was talking about ARIA, and it is mostly asymptomatic, which is true, but that doesn't mean you shouldn't be worried about it, in case that's on your test. All right, appropriate. You didn't know that.
I didn't know that. I didn't look at the test, sorry.
Appropriate use recommendations. So these are the inclusions and exclusions from the 2 main studies, the Clarity and Trailblazer studies. These are not exhaustive in any way. I think the important points are you have to be able to get MRIs to use these drugs. It's probably just not safe to use them without the ability to do MRIs. I don't put a whole lot of weight on the MMSE scale. You'll have certain patients who have certain variants of these syndromes, like, for example, a logopenic or an aphasic variant, where they're going to score real poorly on an MMSE test. That doesn't mean they have more advanced dementia. Some people are just better test takers than others. So I do try to really grade people or stage people clinically based on what they can do. If they score poorly on a MMSE test, if they score an 18 on an MMSE, but they're independent still and they're ADLs, then they are not ruled out in my book. Anyway, the ApoE gene, let's talk about that for a second. You get 1 copy from mom, 1 copy from dad. We each have 2 copies of the ApoE gene. If you have an ApoE4, that basically means that your cells, your neurons, don't traffic amyloid as well. If you have 2 copies of the ApoE4 gene, you're a homozygote E4, that's bad for a couple of reasons. Number one, if you live long enough, you're likely to die from Alzheimer's, so that's bad. And number two, if we want to use these amyloid targeting therapies on you, your risk of ARIA is higher. So you kind of have to know the ApoE status. We still treat ApoE4 for homozygotes, but it's a much more nuanced conversation with them in terms of understanding that risk. Just so you know, you can be on anticoagulants and be involved in these studies and be on these medicines. Anticoagulants do not increase your risk of ARIA, the bleeding or swelling in your brain. The ARIA is probably coming just from the degree of amyloid that you have in your blood vessels, maybe to a degree the robustness of your immune response to that amyloid when it gets tagged, right? But you could be on anticoagulants, you could have other comorbidities. If you have a lot of microhemorrhages in your brain or superficial siderosis, then I wouldn't use these medicines because you probably have just too much amyloid in the blood vessels. So we talked a little about that ApoE4 allele. You can use the meds in E4, E4s. If you're E3, E4, what we call a heterozygote, you have a little bit increased risk of ARIA, and if you are a non-carrier of E4, the medicines are safer in terms of the ARIA risk. The 2 different drugs that are out there have different dosing strategies. One of the drugs, donanemab, is you treat until the amyloid plaque is removed, and then you can stop. The other drug, lecanemab, you treat until the amyloid plaque is removed, generally 18 months. Then you shift to treat instead of every 2 weeks, every 4 weeks, but you continue to treat. And we don't know yet if one of those strategies is better than the other. It's just the difference between those 2 medicines, and sort of exciting for us to figure that out over time. ARIA comes early. I just think of it as the antibody that you put into the blood vessel encounters the amyloid that's in the blood vessels first. It's hard to get the antibody through the blood-brain barrier, but it's going to find the amyloid in the blood vessels, in the blood vessel wall. It's going to tag it. Your immune system's going to come. It's going to remove that amyloid, and that sometimes renders or leaves the blood vessel leaky. That's just what ARIA is. So is it a side effect? Yes, but it's actually the medicine just doing its job. It's kind of us learning how much amyloid is in the blood vessels. So this was back to that dosing schedule I mentioned. For donanemab, it's every 4 weeks, 30 minutes. The dose is titrated over the first 4 infusions. And then once the amyloid is removed, you're done. For lecanemab, it's every 2 weeks, 60-minute infusion. It's a weight-based dose, no titration. And when the amyloid is removed, you continue to treat with lecanemab. You need a lot of MRIs in the first 6 months to monitor for ARIA because the majority of the time it is asymptomatic. And let's see, a question, PQ4. I would sing, but it'd distract you from answering. There we go. All right, symptoms, signs consistent with ARIA that should trigger an out-of-sequence MRI. So if you're treating people or, one of your patients is being treated and they come in to see you with some new neurological symptoms, it's okay to get more MRIs. You don't have to wait for the predetermined MRI schedule. And it's kind of, it's kind of common sense. I mean, if you have a patient who has migraines and they have a migraine, you don't necessarily have to go get an MRI every time they have a headache. That would be overkill. But if you have a patient who doesn't have headaches, who starts to get headaches now, I might want to check an MRI just to make sure there isn't ARIA. There could be mild ARIA, moderate ARIA, or severe ARIA based on the symptoms. Severe ARIA, just so you know, less than 1% risk if you're an ApoE33, if you're an ApoE34. If you're an ApoE44, the risk is about 3% for severe ARIA. So I think, in my book, pretty low. Here's a wallet card thing. So we don't do this in our practice, although it's probably a good idea. The main point is if you're on these drugs and you have a stroke-like syndrome and you go to the ER has to know not to give you TNK or TPA. So sometimes it's nice to carry something like this. Here are some patient registries, real-world use of these therapies. I'm not going to spend a lot of time here. Answer this question. Everyone's fast now because we're running out of time. You guys are all on the ball. And I will say that there's trials going on, lots of them, including trials with lecanemab and donanemab that are looking at, again, as we mentioned, these pre-symptomatic patients to see if we can nip this in the bud. Once the horse is out of the barn, it's too late, but the earlier we treat, the better. You know, there's also trials going on with lots of other meds. The GLP-1s, those are, I know, our big topic of conversation at this meeting. I was told those drugs can do everything, except I did learn that they do not regrow hair, unfortunately. And that's that.
All right. So I think now we are going to break out into our cases. We have 3 cases, and I think each group is going to tackle one of them. And there are facilitators at some of the tables. So please we're going to spend about 10 minutes doing this. And then the 3 of us are going to wander around. If you guys have any questions, there's actually some really good questions here, but we're going to tackle that after we regroup. So go ahead and chat. All right.
Good. Have fun.
right.
Go back up. Oh, hello.
I think our Kristen and
we
Dr.
can make
Wolf,
sure we
if you
connect.
guys want to come on up. For any of the facilitators, if they want to pop up to some of the mics, and we can start discussion. And I'm going to kind of meld together the discussion about the cases and the question and answer, because there's been some really, really good questions that I want to touch on. But let's start with case 1. I'm not sure. I think Kristen. Oh, yes. Do you want to come on up?
No, yeah, I was just helping.
Oh, sorry. So, facilitator for group 1. So, what was the? Do you want to? Can we put the cases on the screen? Is that not what we're going to do? Just for those that were not in group 1, possibly. All right. Do you want to? All right. So go ahead. What?
Oh, perfect.
Tell us. There we go. That's what I was looking for. So we have a 74-year-old man with behavioral and cognitive changes. So why don't we go over that case if you want to go ahead and get started?
Okay. Do you want me to read the case study?
Sure.
Okay. So we have Boyd. He's our friend here today. White male retired accountant attended his annual well visit exam with his wife. Wife is reporting he's experiencing some impairments in organizational skills and judgment, behavioral disinhibition, and diminished personal hygiene. She first noticed the symptoms about 2 years ago, and they are getting worse. Lately, he's been using more alcohol, and he reported that he personally hasn't seen any of these changes and that his wife is going crazy. PCP administered the MMSE, and score was 22, and he's referred to neuro. He's on lisinopril and metformin and aspirin because he has hypertension, type 2 diabetes, and arthritis controlled by meds. Family history: father died young in an accident, so we don't really know that side of it, but mother died of heart disease at 82 years, no family history of dementia. MRI findings show moderate bilateral parietal and hippocampal atrophy, say that 10 times fast. Moderate small vessel ischemic disease, 2 lacunar infarcts in the left putamen. Honestly, it's been a long time
That's
since
good.
high school. An area of superficial siderosis. So neuropsychological testing indicate deficits in executive functioning and processing speed, and the amyloid PET scan was abnormal, indicating moderate to frequent amyloid beta neuritic plaques. All right, so that's Boyd. So first question was, how do you interpret Boyd's amyloid PET scan findings in the context of his overall cognitive and behavioral symptom profile? The group felt like most likely he has AD, but that we also do have some other concerns. So the alcohol use is, there was some concern that may be contributing to some of the changes that we're finding, and certainly some of the behavioral disruptions as well. We did talk about the small vessel changes. Could this be vascular related? He has diabetes, he has hypertension. So essentially, maybe need a little bit more information. And then would you recommend any other diagnostic testing for Boyd at this time? The group wanted to actually know his levels, like his B12, his chem panel, CBC, TSH, A1C. We were talking quite a bit about the use of the blood biomarkers and how that would play into all this. And we thought that it would be helpful in helping to distinguish amyloid-related disease with some of these other concerns that we have. And really great point was brought up is, especially with some of the other things that are going on, depression and anxiety screening as well, that there may be some comorbid issues, self-medicating and such. So I thought those were some really good answers. What care plan would you recommend for Boyd? So the group, overall, we really felt like we needed so much more information, including some of the results of those tests that we would have ordered. But the group did want to do that genetic testing to see the ApoE4 to kind of assess the risk for ARIA for treatment. But overall, just really felt like we needed more information. Care plan, definitely working on alcohol dependence, and then also concerning about the alcohol plus diabetes factor and the hypoglycemia risk and how much that might be contributing. And then is he a good candidate for amyloid targeting therapies? And we had 15 seconds left for this part, so short answer was maybe,
Right.
maybe not.
Well, and I think it's important to mention that these cases are not meant for us all to be like, yay, amyloid targeting therapies, every patient gets this. Because I know at some programs, they're like trying to tee it up for us, but I think the point is that not everybody is a good candidate for it. And this might be one where maybe it isn't, and they could have AD, certainly, but multiple strokes, alcohol use history, I don't know if I would necessarily want to put them on our amyloid targeting therapy, but it just gets the juices flowing and the conversation going. Great points about ApoE. Figuring out what thyroid and B12 looks like. So it's a really important point to make. And these are not all supposed to be, hey, this is what would I do next? Amyloid targeting therapy, right? That's not really the intention. It's just to get the conversation going. So it's a good point to make.
Perfect.
Yeah, thank you so much. All right, so do we have a facilitator for group 2? All right. You want to read the case?
Sure. Celia is a 59-year-old African-American female who's a real estate agent, and she was brought in for progressive memory concerns such as forgetting how to drive around in certain neighborhoods that she frequents and mixing up which days she has certain appointments. Her PCP administered the MoCA, and she had a score of 25. Currently on lisinopril, metformin, aspirin, apixaban, and escitalopram. Medical history includes hypertension, type 2 diabetes, arthritis, atrial fibrillation, and depression, and it states all controlled by meds. MRI findings show mild to moderate bilateral parental atrophy, minimal bilateral frontal atrophy, mild bilateral hippocampal atrophy, and mild to moderate small vessel ischemic disease, and 1 lacunar infarct that's less than 1 cm. She was referred to a neurologist for further AD assessment. Amyloid PET was ordered and confirmed to confirm or exclude AD as the etiology for mild cognitive impairment. Amyloid PET scan was abnormal, indicating moderate to frequent amyloid beta neurotic plaques or neuritic plaques, and neurologist ordered APOE genotyping, and she is E4E4 APOE. Our group did note that with a MoCA of 25, it does put her in that mild cognitive impairment phase. One of the first things that we noted was that, where are the other lab testings? So like, where's the B12, where's the TSH and things like that, along with, where are the biomarkers? So the p-tau 217, hopefully. That in addition to the full functional and behavioral workup, I think would be more imperative for us to go further down as far as if we were to recommend if there was going to be ATT treatment or not. So that's the first thing, first and foremost. And then even though it says all controlled by meds, how long is she be on the escitalopram, let's say, as far as the behavioral treatment? If she's been on the same dose for the last 10, 15 years, okay, cool, that we're probably okay. But, more remains to be seen once we actually see what the behavioral health assessment shows us. What else? So probably not a treatment for ATT, but would we absolutely say absolutely not? That's nose goes, that's not me, that's when I send to you guys. So,
Was there any questions in your groups concern regarding apixaban? Did anybody mention that? Okay. Yeah, so apixaban, obviously anticoagulant. Dr. Wolf already touched on this, but certainly not an overt contraindication, but does warrant a conversation, certainly. There were patients in the clinical trials that were allowed in. So that is something certainly to be important. And I think some of the limitations of this case is we could have written more, but this is already dense.
Yeah.
So some of the thyroid testing, B12, totally get you and I totally understand. And I agree with you wholeheartedly. You definitely want to rule those things out. So, cool. Well, thank you. Yes?
Does the E4, put them at higher risk with ARIA if you do amyloid?
Yes, 100%. And the data is, it wasn't talked about in this talk, right?
Well, first of all, good job, groups 1 and 2. Nice work. These cases are hard because these patients, just to be clear, have Alzheimer's, right? Their amyloid PET, which is the gold standard test, is abnormal, right? They have amyloid. Patient 1 also has probably a mixed dementia picture, and that area of siderosis, which is just basically a little bleed on the surface of the brain, that's what superficial siderosis means, that puts them at a higher risk of having ARIA. And having E4, like patient number 2 has E4, puts them at a higher risk of having ARIA. So these patients could both go on anti-amyloid therapy, but it would depend upon the risk tolerance of the doctors and PAs and the patients, because these are hard, nuanced cases like that. But you can go on these drugs if you're on an anticoagulant. You can in the Trailblazer study, just to be clear, you were allowed to be in the study with one area of superficial siderosis. So you could.
Give our patient a GLP inhibitor?
Sorry, I didn't.
You saying, can you give them a GLP?
Yeah, he has
I
diabetes
think,
as
you know,
well.
GLPs are being studied for many, many different things, but I don't think there's any contraindications if they get a GLP for, let's say, obesity or diabetes, and I think they could still get the amyloid targeting therapy. So there's no contraindication, I think, if that's what you're asking. But they're being studied in dementia, certainly, so, but yet to be determined what that looks like. So. All right, group 3. I guess you guys are tag teaming, right? So do you want to, Dylan, do you want to start, or would you like to start?
I can read it. Do you want to do like the first two and I can do
Oh, yeah, you could read and then you could comment. Sound good?
Okay, so group 3 had Timothy, a 66-year-old man with memory concerns. He's an Asian American male economics professor who's still teaching part-time, reported that he began skipping Tai Chi steps without realizing it until later. He's still high functioning with no other cognitive symptoms. He had a MoCA score of 30, and he was referred by his PCP to neurology for biomarker testing. He's not on any medications right now. His medical history includes mild osteoarthritis. He has a family history, mother who's 87, is currently living in a nursing home with severe dementia, and his father died of colon cancer at 79. His MRI findings show brain unremarkable for acute changes, cavernous malformation in the left basal ganglia versus remote injury, and white matter change and atrophy normal for age. His biomarker testing and management showed that a plasma p-tau217 was ordered, but the results were intermediate/inconclusive. His amyloid PET scan was done, and it was abnormal, indicating moderate to frequent amyloid beta neuritic plaques. He was therefore diagnosed with mild cognitive impairment due to Alzheimer's. He is homozygous for E4, and he's interested in starting treatment with an amyloid targeting therapy.
All right, Dylan, you want to?
Yeah, so this is another tricky one, of course. We were kind of debating whether if we were all primary care practitioners, if we would have ever actually referred this patient versus just watchful waiting because he had a perfect MoCA. But with noticing some missteps on his Tai Chi and having a family history, it kind of is justified. And then obviously with the testing, it's very justified. We said for further testing, we would want some B12, TSH, CBC, CMP, kind of the reversible causes. Maybe refer for neuropsych testing to get a baseline. We talked about getting a functional score on him, like a baseline FAQ, potentially PHQ-9 or GAD if that's appropriate. And then, again, the same question of, is this an appropriate amyloid reducing patient? And we kind of went back and forth. It was a mixed opinion on that. We wanted to definitely counsel him on the risks that are there with homozygotes, especially really review the MRI monitoring, the time commitment that these meds take, and then, yeah, kind of going over side effects with these infusions and the pros and cons of starting him on it. And ultimately make it a shared decision-making.
Yep. No, that's a really good point, and you're right, Dylan. That this was actually pseudo one of my patients from practice, and I don't remember exactly what his MOCA was. I think he was very, very early on, and I actually debated with the patient. We talked through it, but because when he first saw him, he was talking about missing Tai Chi steps. I was like, oh, it doesn't sound that bad. But the guy was like super freaked out. He had been doing it for 30 years. He's like, there is something wrong with my brain. So this was a very, I think, important case for me to recognize when patients are their own advocate. He is a very unique individual and very smart, almost to a fault. So it was a situation in which he did test a little bit poorly, but I think it goes well with Dr. Wolf's point about you take the whole patient, not just the screen as fact. We were talking about utilizing some of the cognitive assessment screening tools for patients of other languages. These are important points, and I think we're still trying to figure this out. But the most important thing is just have a very low sensitivity for cognitive testing. I think that's ultimately what we really, really want. And then, another kind of take-home message really that's important is, those of you in primary care and geriatric medicine, these are things that you guys absolutely can order. You can order these tests. If you feel comfortable doing it and having these conversations, please do. So that is it for, I think, the cases. Any questions or comments additionally? Yes.
The only thing I was going to say, just to echo, sorry, I don't know if someone had a question.
Oh.
But just to echo on what Dylan said, our group said, as far as would you have referred Timothy to neurology, we said yes. And as far as further testing we would recommend, we said the same thing, baseline labs.
Sure.
Would we start treatment? We said yes, but explain the risks of therapy to include the increased risk of ARIA and then side effects of the medication. And then if he is a candidate, which we said he is, what strategies would you use to mitigate the risks associated with the ATTs? So we said the serial MRIs, staying active just for overall lifestyle, patient and care partner education, looking for symptoms of ARIA, infusion-related reactions, talking about those, overall nutrition, having a balanced diet, emphasizing unprocessed whole foods as much as possible, and then carrying the wallet card.
Nice. Well, thank you for that.
3. And I think I would lean yes on Tim too, I think.
Yeah.
Again, the MOCA or the MMSE, he scored a 30 out of 30. He's still working as a professor, but he's noticing that he's not himself, right? So maybe you need some more detailed neuropsych testing in him to tease that out. If he was understanding of the increased risk of ARIA as an E4, and also understanding as an E4 that he was going to probably have more severe dementia, then I'd be for treating him too.
So whoa, we got a lot of hands up. Okay, if anybody has a hands up, has a question, can you actually come up to the mic just for those people that are if you feel comfortable, or submit it on here. I'm going to touch on a few of these questions. I don't know if you want to touch on them, but one question, pretty straightforward, says, do the new drugs actually improve cognition or just slow decline? They don't improve cognition. I mean, it's straightforward. It slows decline. And, individually, it's hard to know for sure. But the fact of the matter is, statistically speaking, in the studies, these patients had a decline. They had a slower decline over the course of the study.
I had a question about the applicability of neuromodulation with AD patients. So as far as because I know that there's a lot of evidence coming out for TMS and DBS with these patients. What do you guys, what have you found in your clinic applicability there?
I think I'll take that one because I probably could say I don't know better than you guys can say I don't know. But I think that we don't know. So whether there's going to be TMS, DBS in terms of functional neurosurgical treatments. Those things may come, but as of now, we're not using them in our clinic. And as far as I know, we're still in the exploratory experimental phase.
I want to tackle one of the questions on here. It says, will you speak to early onset Alzheimer's disease? Dr. Wolf, you actually had a case just recently where he was 52?
Yeah, that's, I think, my youngest, 52. So, I think it's the same disease, but in my mind, a little different disease if you're in your 50s as opposed to in your 70s or 80s. But you can have Alzheimer's disease young, and it's, you know, it's still the same equation. I want to get you as early in the process as possible, and I want to get rid of the amyloid if I can safely do so. So for those patients, these medications, these sort of revolutionary disease-modifying Alzheimer's medicines that we're talking about are, you know, they're really amazing if you're one of those unfortunate early onset patients.
Do you have a question?
That's part of my question. So when you were going through your slides, the way I interpreted that was these medications delay onset by 5 to 7 months or 30%. So my question is, you know, when we're looking at the trajectory of dementia, and I'm going to give someone a medication where they have to go to frequent MRIs, there's all these risks. It's probably very expensive, I assume. You know, I'm in primary care, so just on your perspective, like, how significant are these benefits? Because if it was my loved one, and I'm going to give you 5 extra months before we're starting to see the progression that we were already seeing, that's my question. What is the...
So I might have Dr. Wolf tackle it, but I'm just going to make a comment. That whole 5 to 7 months thing, I've not really seen that in a lot of other, like the donanemab studies, the lecanemab studies. It's hard when it's a short study, when it's an 18-month study. To me, you know, the really interesting thing is going to be the extension study. I think both lecanemab and donanemab have 36-month data now. And so it's really going to be more telling when we get longer amounts of data. 18 months is generally a very short time frame for us to really be able to extrapolate that type of data. I think Dr. Wolf always says, and I'll let him say it, we just want to get rid of the amyloid.
Yeah.
I mean, that's really the most important thing. Now, long term, we'll see what that looks like clinically.
I don't want you to think about it on an individual person basis that it slows disease progression by 27% or saves you from progressing to the next stage by 5 to 7 months. Okay, on a study basis with 900 people in each arm of the study, those are true statements, and that's how we got these drugs approved, which is amazing, right? But all I tell patients, and I think all you should think about, is that these medicines, they remove the amyloid. They will normalize your amyloid level, assuming you don't have side effects from them. Your amyloid level will drop to normal. On an individual basis, we're not 100% sure what that means. If you're early and you haven't had the catastrophe going on where the tau's building up, then it might mean that you stay stable for a long, long time. And I certainly hope that's true, right? It could mean that you're progressing, just not as fast as you would be progressing if we left that amyloid in there. So I really try to stay out of answering the question of what is this going to mean for me, because I don't know the answer. I want to see that amyloid normal, and that's going to set us up for the most success that we possibly can.
Do you want to tackle one of
Yeah, I can tackle a couple questions here. So I have one from Christina. Do these biomarkers indicate other types of dementia or no? So as far as the biomarker testing that we talked about today, they are targeted for amyloid, so they are going to be Alzheimer's disease specific. Another question was from Catherine, what supplements do you recommend? I personally, and you guys can chime in too, I personally don't recommend any specific supplements unless they're deficient in something, or, say in that first patient who had history of alcohol abuse, like, I might tell them to take B1 or thiamine, B12 if they're on the low end.
I would agree.
But,
I mean, we're not big supplement people, and certainly some patients really like that, and that's fine, but certainly no problem with B vitamins or ginkgo or vitamin E or things that are generally safe to take, but we generally don't recommend supplements. We recommend a brain-healthy diet, which is usually sort of a Mediterranean-based mind diet. Alcohol is bad in case you want to go out for a drink with me after. I'm okay with it, but if you have Alzheimer's, alcohol is bad for you. So that's a very hard thing to tackle.
What I tell my patients is the nutraceutical industry is a very lucrative industry, so just be careful on what you read. I just don't want it to break the bank. That's the biggest thing. I don't really mind if they want to go on something, they read a book from some neurologist. I have no opposition to that as long as they're not spending thousands and thousands of dollars. Unless they're, Elon Musk's uncle or something, I don't care. But, if it doesn't break the bank, then go for it. There was a question here from those in the emergency department setting. probably one of the biggest take-home messages for those that are in more urgent care settings is most likely we're going to start seeing more of these patients on therapy. So just really be aware if there is any possibility that they could be on these therapies. That's more for us. And to Dr. Wolf's point, we really need to start having our patients potentially wear bracelets. The third case, my patient actually bought something that's like a really nice looking wristband. But there are wallet cards and things because I would just avoid TNK altogether. And if they're coming into your emergency department setting with any new neurologic symptoms, you always want to think of ARIA first rather than stroke because you certainly don't want to give them a thrombolytic.
And that's especially true in the first 3 months. I mean, we'll say 6 months for a little safety measure there, but in the first 3 months of therapy, that's when ARIA happens. So if they're new to one of these therapies and coming in with what looks like a stroke, there was a fatality in one of the studies from somebody who got TPA for a stroke-like presentation when it was actually ARIA, so a very important point.
Lisa asks, what's the best time to start targeted treatment? As early as possible. Boom, easy.
But not yet pre-symptomatic.
Not yet. Yes, that's true. I'm sorry. Yeah. As early as they start developing symptoms. There was a question in here. What would you appreciate that I do? I'm assuming that they're in primary care or stop doing before I refer patients for you from primary care. One of the take-home messages for me is, neuropsych testing is a fantastic tool, but don't let that be a rate-limiting step. In Denver, it takes about 12 months, maybe 6 to 12 months, sometimes more, to get neuropsych testing, and I don't want to just sit around twiddling our thumbs waiting for neuropsych testing to come back before they get sent our way. Certainly you can order it, but still refer them. My big thing is order whatever you feel comfortable ordering. Blood-based biomarkers, MRIs, if you're interested and you're passionate about treating these patients, do anything you want. I mean, I definitely don't think you should not do a bunch of stuff.
Yeah, I had a patient from a geriatrician's office who came to me with their MOCA, with an MRI, with a p-tau 217, and a PET scan. And then I'm like, basically, okay, I just need to rubber stamp that and make sure we're not missing anything. So, as much as you're comfortable with is great. That helps.
Just the big thing with the blood-based biomarkers or any of the testing really is figure out how you want to communicate to the patients because we certainly are good with you ordering the testing, but making sure you understand what the tests mean or at least let the patients know that these are screens. I use the blood-based biomarkers currently as a screening tool rather than an official diagnostic test. We still use amyloid PET scans, but that's going to change as time goes on. So just making sure the patients know if they're ApoE 3-4, having one copy of ApoE 4 doesn't mean they have Alzheimer's, and it certainly doesn't mean they are going to get Alzheimer's for sure. So just understand what these mean, and there's certainly a lot of resources out there for you guys if you want to learn more. Does Medicaid pay for the whole payment? So question is, does Medicaid pay for these biomarkers? Right now, that's difficult to answer. The way I would answer it is I've never once had a patient complain about the cost of these blood tests, but
I haven't had any.
So order away, but just understand that they're not there's one that's now FDA cleared, but the majority of them are not FDA cleared yet. Allie has a question here that says, since biomarker testing is not indicated prior to cognitive decline, but therapeutics are more effective prior to symptoms, could you recommend screening exams for patients with risk factors despite lack of cognitive decline? So I know we've talked about if you put them on this drug theoretically put them on prior to symptom onset, they could do better. That's a theoretical question that has not been proven yet. It's being studied. So I don't generally recommend people get these tests if they're asymptomatic, but that is, I think, where we're headed.
Also, and Kristen went over this, but, when we talk about the sensitivity and specificity of these biomarkers, they're studied in people with mild cognitive impairment. Those numbers, sensitivity and specificity, drop the earlier or the younger you are when you get these tests done. I do believe, this is a belief, it's not fact, right? But I do believe that in the future, you're going to go to your primary care doctor for a routine physical when you're 50, 55, 60. They're going to check these tests. They're going to say, I don't like the way these amyloid and tau are looking. Let's nip this in the bud before it ever becomes a thing. And I think that future will be here, maybe by the end of the 2020s, maybe. But I do think that we're not there yet, but I think in the next 4 to 5 years that'll be happening.
There's a question here that says, do LabCorp and Quest draw the Lumnipulse G test, which I think is the newly FDA-cleared test? Simple answer is no. I actually don't know how to order the new FDA-cleared test. The press release from the FDA says nothing about how to order the test, so I don't even think it's commercially available yet.
But LabCorp, I mean,
They do the testing,
in Denver we have LabCorp and Quest, and probably national labs where you are too, and they do a good job with the p-tau 217. So it's a very good test. You could also send out to some other fancy labs too. Those will cost money. LabCorp and Quest may not be covered, although like we said, we're not running into that issue with our patients. We don't want to promise that, but.
I have a question for you, partly from the question here. It says, why not test blood-based biomarkers in patients that are curious?
Yes, curiosity, I like it. I like curiosity. I test it all the time, to be honest with you. I do my spiel, and invariably the patient will be there with their daughter or somebody else, and they say, can I get the test too? And I'm like, well, sure, yeah, you can get the test. So I like the blood test a lot. Data is good, but you got to be the kind of person who wants the data. Like if you're, 50 years old in my office with your mom, and we test you and you're E4, E4, are you going to be okay with that? Like I would want to know, but not everybody does, right? So, something to consider. But yeah, I think the blood test will proliferate and be done very routinely as a screen. Like we mentioned now, we're kind of using them as a screen, but they're not really proven as screening test quite yet.
Like colonoscopies, right? You don't wait until they have GI issues. You do it at 45. No. Let's find the cancer.
Let's not talk about colonoscopy.
Okay, I'm sorry. I think I had a talk yesterday, and it was like either migraine or Cologuard. So, more people came to ours, but I think it was viable. Sorry for those of you in GI. Do blood-based biomarkers substitute PET scan? Right now, no. I still order a PET scan after.
It's mostly a payer thing, so I think it'll be soon that you can get these medicines approved with the blood test. But for now, you need a confirmatory test, which is either CSF or PET, in order to get these things covered.
All right. I have the equivalent of the Oscars playing the music to tell us to stop. So a few more housekeeping things. Please look at your phone. Thank you all so much, first of all, for all your questions. Thank you for your interaction. Please look at your phones. There does look like there's a green phone over here. There's going to be multiple. If you have something green on your phone, tell someone at peer review. I don't know where I think the peer review people are over there.
Yeah.
A couple of other comments, housekeeping things. I can't actually progress the slide. People are very excited that they've won $50.
Yay.
Peer review.
Just hold up.
If you won $50, just come up to Jordan over here. He's got it.
Hold up your phone if you've got a green phone, basically. There is a post-test evaluation for the credit, and then you can watch. I'm not going to watch it, but you could watch the replay of the event for the next 24 hours.
Oh, really? Maybe
What's
we should
that?
all get together and watch.
Yeah.
Yeah, let's do it. Popcorn. Thank you all so much for coming. I really appreciate your time, and sorry for going a few minutes over.
When were we supposed to?